assigned to give a talk on intraocular manifestation of systemic malignancies.
Good afternoon. First of all, let me thank KSOS Scientific Committee and Dr. Ann for giving me an opportunity to present here. So, intraocular manifestation of systemic malignancy. Intraocular manifestations of systemic malignancy is important both for the ophthalmologist and the physician to recognize, as sometimes they precede the diagnosis of a malignancy. It can affect the eye either by metastatic neoplastic infiltration, as my previous speaker has explained, or circulating antibodies causing paraneoplastic retinal degeneration like cancer-associated retinopathy, melanoma-associated retinopathy, or BIDM. And it can cause a hypercoagulable state causing hyperviscosity syndromes or leukemic retinopathies and anemic retinopathies. And we all know of the toxic effects of chemotherapy which can occur in the eye. So I'll first go through a few cases. First one is a 30-year-old male with no other comorbidities presenting with a decrease in vision in the left eye. His vision in the right eye is 6.6 and left eye is 6.12. As you can see from the picture, there is an elevated lesion with the subretinal fluid around nasal to the disc and involving the disc with the RPE changes. And there is another lesion near the fovea. This is very much suspicion of metastasis. And OCT shows that there is a choroidal lesion which is pushing the retina forwards. P-scan, I don't have a picture, but it showed the classical appearance, that is a high surface reflectivity and moderate internal refractivity in the left eye. FFA in the early stages was not showing any leakage, but towards mid phases it showed pinpoint to patchy fluorescence which increased in intensity towards the later phases. So, with the suspicion of a metastasis, a patient underwent PET MRI by the oncologist, and it was found that there were metastasis, there was a primary left lung malignancy with metastasis to the choroid and other parts of the body. So, the diagnosis is a choroidal metastasis from lung carcinoma. So, metastasis, 1/3 of the patient does not have a history of primary cancer at the time of the diagnosis, and choroid is the most common form of intraocular metastatic process. Breast and lung carcinomas for women, and lung and GI for men metastasize to the eye. So, for our patient, he received chemotherapy and local radiation, and his lesion resolved. Paraneoplastic retinopathy is the second one here. They can be either cancer-associated retinopathy or CAR, melanoma-associated retinopathy or MAR, paraneoplastic vitelliform maculopathy, and bilateral diffuse uveal melanocytic proliferation. So let's go to the second case, which is actually a 32-year-old female with suspected Sjogren's on systemic immunosuppression and investigation for interstitial lung disease. She presented with decreased vision, but visual acuity was 6.6 in both eyes. The anterior segment was normal, no vitritis or inflammation, but fundus showed this sensory nodal detachment supratemporally and nasally in both the eyes. So this confirmed that there is sensory nodal detachment supratemporally, but the fovea was spared at the time of presentation. And B-scan showed a diffuse thickening of the uvea, and FFA, again from early stages there was this pinpoint fluorescence, but it didn't pool, it increased in intensity towards the later phases. Our diagnosis revolved around CSR and BKH, and the patient was given steroids. But if you look at the autofluorescence, you can see there is extensive hypo and hyper autofluorescence which is seen in the autofluorescence, which are not typically seen in acute CSR or acute BKH. So as when she presented with headache, she had an MRI of the spine which showed metastasis, and the primary was found to be in the breast, bilateral breast invasive lobular neoplasm. So that is a case of bilateral diffuse melanocytic proliferation or BIDM from primary breast carcinoma. So how do you diagnose it? It's a rare paraneoplastic syndrome that can lead to profound vision loss and benign proliferation of choroidal melanocytes. It's often associated with occult but advanced carcinoma, poor indicator, poor prognosis. So it is characterized by development of multiple slightly elevated pigmented or non-pigmented uveal melanocytic tumors. Evidence of diffuse thickening of uveal tract, which was there in our patient. Multiple round or oval subtle red patches at the level of RPE in the posterior fundus. Striking pattern on FA of multifocal areas of early hyperfluorescence, which was there, and exudative detachments, which were there in our patient. There was no rapidly progressing cataract in our patient. So this was the first presentation, and going through a lot of confusion and treatment with steroids and all, finally we diagnosed that this case of BIDM, and the patient underwent treatment with chemotherapy, and after the treatment sensory nodal detachment settled down, but then there was diffuse mottling which persisted. So what is cancer? The next one is cancer-associated retinopathy, which is a type of autoimmune retinopathy characterized by rapid visual deterioration in the setting of a distant neoplastic process with It's actually caused by the circulating antibodies against the retinal proteins in the presence of systemic cancer. Some of the times when you look at the fundus, the patient's fundus might be normal, but classically it's like a disc pallor with attenuated vessels and RPE atrophy and extinguished TRG. So management option, treat the underlying cause, then systemic steroids, intravenous immunoglobulin and various monoclonal antibodies as been described. Despite above treatment, visual prognosis remains poor. So melanoma-associated retinopathy, it's on the other hand, it is associated with malignant melanoma elsewhere in the body, and it targets the bipolar cells instead of the photoreceptors as occurs in carcinoma-associated retinopathy. So now this is another case which is very interesting. This patient is a case of non-Hodgkin's lymphoma and on remission and presented with posterior uveitis with features of some amount of disc infiltration and disc granuloma, vitritis, hemorrhage, the string of pearl appearance, periphlebitis, like a sarcoidosis type of picture. So when it comes in an NHL patient, we definitely have to look into whether there is a relapse of the case, and the patient underwent all the systemic investigation under the care of oncologist, and she also require a vitreous biopsy to rule out lymphoma in the eye. And anyway, everything came to be negative, and then she was treated as a posterior uveitis with systemic steroids and immunosuppression. Now she is doing well. She is with us for the past 3 years. Vision is still maintaining at 6.6. So that is one thing which we have come across in literature, sarcoid-like reaction which can occur on non-caseating, non-granulomatous reaction occurring under various conditions in cases of lymphoma, which could indicate a good prognosis. So other manifestations due to malignancy are hyperviscosity syndromes, as can occur in multiple myelomas or in leukemias with presence like a bilateral CRVO type of picture with macular edema. Then toxic effects of chemotherapy we should always bear in mind, like vincristine optic neuropathy that can occur in patients on ALL, on treatment for ALL, or tamoxifen maculopathy on breast carcinoma. And this ETRA-induced or retinoic acid-induced IAH is something we see in our clinic with the neurology. When they start the patient on retinoic acid, these patients can develop disc edema, which is IAH, and these patients need to be monitored to see whether the disc edema is developing, and accordingly they titrate the dosage of retinoic acid. So to conclude, a wide array of ocular manifestations can occur with systemic malignancy, and many a times we are not only the ophthalmologists, we are the diagnostic physician too. Keep our eyes wide open to see if there are any of these features suggesting any underlying malignancy. Do the relevant investigation and do the timely referral. Many a times it will not only save the vision but also the life of the patient. Thank you.